Hi guys, we're going to get started with the neurology lecture. So I hope you all had a nice weekend and hopefully this recording works for you. Let's do the lecture. Okay, so we're going to talk about some neurologic conditions today, including meningitis, cerebral palsy, Down syndrome, structural malformations, and cerebral injury or elevated ICP. Okay, so this is just showing the CSF flow, this photo. And so it starts out in the choroid plexus, that's where the CSF is produced. And then it flows all the way through a series of ventricles and then is absorbed in the arachnoid villi. So this kind of just shows you the fluid, the way it flows through, it provides hydration and nutrients for the brain. All right, so we're going to talk about embryology of the nervous system. So it starts around third week of gestation. The nodal cord develops and the four folds to fold to form neural folds, and then that fuses to form a neural tube. Fourth week, there's closure of the neural tube, and a defective closure of the caudal end will cause spina bifida. So spina bifida forms very early, by fourth week of gestation. Then, the weeks beyond that is just increasing the number of neurons. So a lot of the development occurs early on. All right, so a neurological assessment. So for an infant or young child, most of your information about their neurologic system is obtained by observation. So you just watch them interact, what they can make eye contact, verbalize, do motor planning, so what interactions they can do. With a history, you want to get a family history, and especially a prenatal and birth history. So you want to know, for the mom, what were the APGARs? Was there any poor nutrition? What was the course of the birth? Were there any injuries at birth? And then also a history of present illness. So when did the neurological symptoms start? How did they evidence? What's been different than how the child normally behaves? Okay, so you want to have an accurate and objective baseline. So a lot of that is obtained if you're just seeing a patient in the hospital while they are ill. Then your baseline is obtained by talking to the parents. You want to have documentation that's descriptive and detailed, so that if there's a neurological change, you can go back to your documentation and say, no, their pupils were reacting earlier, or they were able to move their left side earlier. So this is a new development, so you know what changes happen. For level of consciousness, this is super valuable clues as to what's going on in the brain. So you want to look at vital signs, cranial nerve testing, which hopefully you guys learned in assessment. You want to observe the posture and movement, both spontaneous, what the kids are just doing on their own, and then elicited, just asking them to grab this toy or walk across the room. You want to look at their eyes, check pupils and extraocular eye movements, and then you can also test their reflexes. All right, so as far as vital signs, the temperature, you might see with a neurological illness or issue, there might be an increase in temperature. It could be related to an infection or an injury to the brain. Sometimes if there's enough damage, the body can't regulate temperature as well. With respirations, you might have slow, deep respirations that could be related to being on a sedative, or maybe being post-ictal after a seizure. Irregular respirations would be more associated with some type of damage to the brain stem, and that would be a bad sign if they were to the point where they were having irregular respirations. And then you can also have hyperventilation. The pulse might be rapid, slow, or feeble. So, under different conditions, the heart rate might do different things. And then blood pressure could also be normal, elevated, or low. So vital signs really just depend on what kind of neurological illness is going on. Okay, so you also want to look at the skin and look for bites, ticks. You want to look at the eyes, eyelids, and pupils we talked about, and then movement, sensation, and posturing. So there's two types of posturing that we talk about. One is flexion or decorticate, and that's a indication of severe dysfunction of the cortex. And this is when most of the extremities and muscles would be flexed, kind of curled up. And then there's also extension or decerebrate, and everything is extended. So the arms are out straight, and you might even have arching of the back, and that indicates dysfunction of the midbrain. Okay, so we do use the Glasgow Coma Scale. There's a pediatric variation to it, and this is an objective assessment of level of consciousness. Hopefully you learned about it in MCA. So level of consciousness is the earliest indicator of a change in neurologic status. That's probably important to know. And so we really want to assess their level of consciousness early and frequently so that we know and can recognize any changes in their neurologic status. So the four components are pupils, eye opening, best verbal response, and best motor response. The best score is a 15, and then 8 or less is a coma. So often, if a patient comes in an emergency situation, a Glasgow Coma Scale or Glasgow Coma Score is a way to quickly say how the patient is doing neurologically. Okay, so this just shows the pediatric Glasgow Coma Scale. I think it's fairly similar to the adult scale, but just changed a little bit for how, especially how kids how they verbalize or their motor reactions. So you can take a look at that. You do not need to have it memorized. It probably would be good to be familiar with the categories, but we don't need to memorize the scale and the numbers. This just shows for best response to auditory or visual stimulus, and so these are the adaptations they made for a child. So less than 2 years or greater than 2 years, how they get scored for responding to auditory stimulus is different. Okay, so meningitis we're going to talk about. So this is an acute inflammation of the meninges. There are 3 types: bacterial, viral, and tuberculosis, which is unusual. Bacterial, it's often caused by strep and gram-negative bacilli, and then Neisseria meningitis. The H influenza strain is very uncommon now because we have the Hib vaccine, which is great. 90% of cases are in children 1 month to 5 years, so that's when it would be most common to see a patient with meningitis. So bacterial meningitis occurs more often in boys than girls. It's the greatest morbidity is in neonates to 4-year-olds, so younger children. And then you're more susceptible to bacterial meningitis if you have a central nervous system abnormality, sickle cell, or other infections. Meningococcal meningitis may occur in epidemic form and is readily transmitted by droplet infection from secretions. So that's what can pass around like colleges or schools, and so you know, the meningococcal vaccine has been really helpful for that. Okay, so the pathophysiology of bacterial meningitis. So the most common way is vascular dissemination from other infections. So maybe they have like a cold, and then they get a sinus infection, and those, you know, from that area, it disseminates into the brain from the sinuses. Or it could be from penetrating wounds, a skull fracture, anatomic abnormalities. There's just some way that bacteria can access and get into the CSF. The problem is that as common with any infection, there's edema and swelling, except for this time it's swelling of the brain, and there isn't room for the brain to swell in the cranial vault. It can also extend into the ventricles and obstruct the CSF flow. So that is also a huge problem, because there's no way for this CSF to be drained, and also there's no way to replenish the nutrients that the brain needs. Okay, so this slide talks about the clinical manifestations of bacterial meningitis. So for children and adolescents, they'll have an abrupt onset of fever, chills, headache, vomiting, seizure, photophobia, so they won't want to be around bright lights, and then nuchal rigidity. And Koenig's sign is a test that you could do to diagnose bacterial meningitis. And it involves the patients lying down, and the physician or nurse would try to extend the legs while the hips are flexed, and the patient would have pain. And then Brzezinski's is when the patient, the neck is flexed passively by a nurse or physician or whoever, and the patient will try to flex their hips and knees. You can look those up, but those are good tests to know. And then they could also have GI URI symptoms, a petechial rash if it's caused by meningococcemia. And then infants and young children can have fever, poor feeding, vomiting, or a bulging fontanelle. So that fontanelle is kind of a little window into the brain, lets you know what's going on. If there's increased ICP, then you'd have a bulging fontanelle. And then neonates are kind of more vague symptoms, like poor suck, vomiting, diarrhea. They'll just look like they're not doing well. Okay, so treatment. So bacterial meningitis is a medical emergency. It's treatment needs to be started as soon as possible. So you want to put them on isolation, and then you want to start IV antibiotics, and it's at a higher dose because of the blood-brain barrier. And then you want to monitor neuro signs, maintain hydration, ventilation, clotting times. You want to observe for signs of shock, because this can turn into a bacterial blood infection. And then you want to treat seizures, which can happen with increased ICP. Okay, so nursing considerations, we want to assess neurostatus frequently and ICP, so assess for signs of increased ICP. Decrease stimuli. A lot of patients that have this, we will take away their phones, or even limit their time of watching TV, and turn off the lights and just give them a quiet place to kind of heal and allow their brain to rest. We can increase the head of bed, or side lying is another good position, and no pillow for these patients. You don't want anything to put pressure and obstruct the return of CSF. And then evaluate and treat their pain. We already talked about isolation, do seizure precautions, antibiotics, and fluid therapy, and help them control their temperature. Okay, so viral can be caused by measles, mumps, herpes, enterovirus. It can be abrupt onset or gradual, and it's a generally self-limiting disease, and most of the time they don't have any complications afterwards. And the symptoms are similar to the other ones with headache, fever, malaise, and GI upset. Okay, so diagnosis and treatment of viral. You do the same tests as with bacterial, and mostly that's to rule out a bacterial cause. And then you treat the symptoms, and you do not need isolation. Once you decide or figure out that it's viral, then they come off isolation. And usually they recover within 3 to 10 days. This is a really important slide because it is describing the differences in the CSF when there's a bacterial meningitis versus a viral meningitis. And this is commonly tested perhaps on my test or on the NCLEX. So definitely study these different information. And if you think about it, it makes sense. Like with bacterial, you'll have increased white blood cell count, and viral, you'll have a slight increase, but also lots of lymphocytes because they're fighting off the virus. In bacteria, less glucose because the bacteria are eating all the glucose. And so anyway, there's ways to kind of think about this, but definitely memorize this slide. It's very important. So this is if they did an LP then and got some CSF, then they would analyze it, and then if it matched one of these, then they would think, oh, more so that it was bacterial versus viral. Okay, so we're going to talk about seizures. So they can be idiopathic, acquired, or secondary to another disorder that the patient has. Basically, the brain's electrical system malfunctions and fires, in a disorganized manner. So epilepsy is a disease that essentially means that they have chronic seizures that are recurrent and unprovoked. So someone can have a seizure but not technically have epilepsy. They have to have multiple recurrent seizures. Okay, so most seizures are idiopathic. We don't really know what causes them. They just kind of happen. Acquired is when there's an insult to the brain. So they might have an injury to the brain during prenatal, natal, or postnatal period. It could be also from a trauma. So if they have a head injury, hypoxia, like maybe a stroke, infections, toxins, or fever. These can all lead to a seizure. In neonates, most common, it's they can have a seizure because of a birth injury. And then less than 3 years, it's usually caused by an infection. And then greater than 3 years, it's most likely idiopathic. Okay, so seizure classifications. So simply put, there are partial seizures and generalized. So partial means there's like a localized motor or sensory symptom. So it could be like just one side of the body or one limb, and it can also be just a change in the level of consciousness. So like absent seizures, when they just stare, they're just more of a localized symptom, and then they can progress to a generalized seizure. And a generalized seizure is what you would commonly think of, so tonic-clonic seizures, and they can have loss of consciousness, become apneic, and what we used to call grand mal is now called tonic-clonic. An absent seizure is actually a generalized because it's a brief loss of consciousness. So this is the seizure that they'll often talk about, that when a kid is just zoning out and you think, oh, they're never paying attention in class. Really, they're having an absent seizure. And they don't have little to no change in behavior or muscle tones. It's less dramatic than the tonic-clonic, but it's still a generalized seizure. And then there can also be an unclassified seizure. Okay, so there's a couple different stages that you go through with a seizure. So, an aura is what a patient might smell or feel prior to a seizure, and some patients can say they'll know, that they're about to have a seizure, and sometimes if they have enough of them, they can kind of get into a safe position or be ready because they kind of feel it coming on. Then there's the ictal state when the symptoms of the seizure happen, which might be staring, like an absent seizure, a change in level of consciousness. They might do some lip smacking, drooling, blinking, hand movements, tonic-clonic, with jerking, or they might become incontinent. So that's like the kind of active stage of the seizure. And then the post-ictal state is after the seizure, when they are drowsy, uncoordinated, aphasic, confused. So kind of just when they're recovering from the seizure. Okay, so the management of seizures. You try to identify triggers, or if there's a cause, treat that. During a seizure, you want to have really observe it and document what type of seizure, when it happened, how long it lasted, what was the patient like during the seizure. You need to educate the family, caregivers, school personnel, anyone who's going to interact with the child so that they know what to do if it happens. And then there's tons of anti-seizure medications. There's some listed there. These are really strong medications and they have horrible side effects. And so it really impacts their life if they have a seizure disorder. But these medications can make the patients seizure free, or at least reduce the frequency, which helps them live better quality of life. And so you want to help them live a normal life whether they're having seizures or not. Help them to progress in school and socially in different areas of their life. Okay, nursing care. So you want to protect the head and airway. This is if they're actively having a seizure. You want them on their side to facilitate drainage and kind of protect that airway so that if they're so they don't aspirate, and then provide them privacy. So if this is happening on the unit, close their door, close the curtain so that it's not a spectacle. You want to reassure them and their parent, and then you want to check their vital signs after the seizure. Make sure to record the length and whatever else is going on at the time, or what their behavior is during the seizure, and then also administer and monitor for the side effects of anti-epileptic drugs. You also often check levels of these drugs because they are so strong and can have bad side effects. So you might be drawing drug levels when they're getting started on the anti-epileptic medication. Okay, neural tube defects. So spina bifida is the failure of the bony spine to close. So it can be occulta or cystica. So occulta is not visible externally, and it occurs in 10 to 30% of the population. So this is very common. Spina bifida cystica is when there's a visible defect in the external, with an external sac-like appearance. So on their backs, there's a little sac that you can see. Meningocele is when it's meninges and spinal fluid, and then myelomeningocele is when it also includes nerves. So neural tube defects happen more commonly in boys, Caucasians, and 50% are caused from a nutritional deficiency of folic acid. So this is why it's so important for moms or pregnant women to take their vitamins and eat healthy, because they can prevent this horrible defect if they are eating enough folic acid and taking their vitamins. It's also associated with hot tubs, valproic acid, and a familial tendency. Okay, so if they have spina bifida occulta, they might have no neurological disturbances or symptoms. However, sometimes they don't have any symptoms until the child starts walking. They can have foot weakness, a change in their gait, and then bowel and bladder disturbances. And there's kind of like a spectrum where some people can have no symptoms and then other people can be really severely impacted by this. Okay, so myelomeningocele. In the first 28 days of pregnancy, the neural tube fails to close. and this sac protrudes, and it's kind of in the lower back, and the location and the size of the defect determine the extent of the neurologic symptoms or involvement, so how they are able to function neurologically. So here's a picture, sorry it's kind of blurry, but there's a picture of a myelomeningocele, so you can kind of see what a defect would look like if a baby was born with this. Okay, so the diagnosis. So for prenatal detection, they can have increased AFP around 16 to 18 weeks, and which is the alpha fetoprotein. And then MRI or CT can determine like the severity. So if they have increased AFP, then you can see how severe it is. And then if they have a defect below L2, they can be flaccid, or have flaccid lower extremities, and varying degrees of sensory deficit. So some of them still have their sensory nerves intact and others don't. And then they might have issues with bowel and bladder control and joint deformities. And then also a lot of these kids will have a Chiari malformation, which is a downward herniation of the brain into the brain stem. And that can cause hydrocephalus because it disrupts the CSF flow and can cause the fluid to accumulate in the brain, which can also cause apnea. Okay, so the treatment. So for myelomeningocele, you want to close the spine within 12 to 18 hours. To decrease the further damage and protect them from infection. So this is obviously a huge infection risk because they have an open area into their neural system. So you want to close it as soon as possible. And then you can place a shunt for hydrocephalus, and then manage orthopedic issues with their lower extremities, genitourinary, bowel control, and then it really is an interdisciplinary team that you need because they have all these different issues. Because they're spina bifida, there's not one doctor or one therapist or one team member that can control this. It really has to be, they usually have a clinic, a spina bifida clinic, and they might have someone with nutrition and someone with OT and PT and a neurologist and an orthopedic surgeon and different people involved. Okay, so nursing care, you really want to support the family, of course, always. Protect them from infection. Identify early signs of infection so you can treat it. You want to support the sac to prevent further damage to the neural system, and then provide skincare, neurologic assessment, and latex allergies are really common with kids with spina bifida. I'm not sure why, but it's something that a common association is spina bifida and a latex allergy. Okay, hydrocephalus. So 90 to 95% of infants with myelomeningocele will develop hydrocephalus. So these two are often, they go hand in hand. It might not be apparent at birth, but then shortly after it presents itself. So the neural tube actually disrupts the flow of CSF and then it builds up in the brain. So this is just a little baby. You can see that has hydrocephalus. So this is what they typically look like, with kind of a large forehead, and you can tell that skull is being expanded, and the fluid is pushing out on everything. Okay, so the pathophysiology. There's impaired absorption of the CSF by the arachnoid villi. Remember I showed you at the beginning picture of the CSF flowing. So for some reason, the arachnoid villi, it's like a draining system, and it is not absorbing the CSF enough. And so it can also be caused by an obstruction of the flow through the ventricles. So if there's like a tumor, again, a myelomeningocele, head trauma, infection, these things can obstruct the flow even just between the ventricles. To diagnose, you do an ultrasound, and as early as 14 weeks gestation, you can diagnose this. They can also do flow studies, a CT and MRI. And so to treat it, you can do a direct removal of the obstruction. So if there's like a tumor or an abscess or something, obstructing the flow, then you can do surgery. Or you can place a shunt to reroute the flow and to absorb the CSF. So it is a secondary way to kind of drain that CSF. Okay, so for hydrocephalus, usually what's placed is called a ventriculoperitoneal shunt, a VP shunt. You can also do a ventriculoatrial shunt, but VP shunts are much more common from what I've seen. So basically, there's valves that control the flow of CSF drain from the head to the area for reabsorption. So either it goes from the ventricle to the peritoneum, or from the ventricle to the atria. So it may need to be changed as the child grows. Obviously, it's a tube, and so the child may outgrow it. Or it might become obstructed or infected, and you need to act quickly if that happens to a child with a VP shunt. Okay, so here is a VP shunt. You can see that it's inserted into the ventricle and then kind of goes behind the ear, underneath the skin, and then goes into the abdomen, and that's where it drains the extra CSF. So basically, if someone has hydrocephalus, it is a way to drain that extra fluid off of the brain. And here's a little animation showing a ventriculoatrial shunt and the direction it takes through the body. Okay, so shunts are really, they're kind of scary. So if a child comes in and has a shunt, I feel like there's just a heightened level of concern, because it's such a risk for infection or malfunction. And if it malfunctions, then you're going to have a buildup of CSF, which causes increased ICP, which can damage the brain. So you just have to be really careful with these patients. So there could be an obstruction, like the VP shunt could get kinked, plugged, or separated, and then there can be infection. Obviously, having that tube just causes, it's another portal for infection. So, and the infection can include the valve or the tubing, and you would need to remove the shunt. And then, they can temporarily place an EVD, which is an external ventricular drainage system, to allow the extra cerebrospinal fluid to still drain. But you want to do it slowly. If you quickly decrease ICP, you can actually cause a subdural hematoma. So you have to slowly adjust things. And this patient would definitely be in the ICU. And then also patients can get a peritoneal abscess from the drainage in the stomach or abdomen. Okay, so nursing care for a child with shunt. The most important thing is your assessment. So assessing really thoroughly and frequently, so you can quickly recognize if there's a shunt malfunction, infection, or symptoms of increased ICP. You can support the family, educate them about what symptoms or things, could be worrisome, or when to bring their child in, and then refer them based on, the needs that they have to other resources. So some complications of hydrocephalus. So the prognosis depends on the size of the cerebral mantle before the shunt placement, the amount of irreversible brain damage, and the cause of hydrocephalus. About 2/3 are intellectually normal after a shunt. So as long as that CSF can start being drained, they can have, good brain function. And then if they have ocular defects, that's associated with more of a developmental delay or mental disability. And then they can also develop seizures because of the hydrocephalus. Okay, these are symptoms of increased ICP, and so these are the warning signs that would be very serious in a child that has a shunt, or any child that you're concerned about increased ICP. So headache, nausea, vomiting, diplopia, blurred vision, kind of any vision complaints, and then seizures. So if a child with a shunt develops these, then they would probably just need to go straight to the ED to be evaluated. And it might be that they just have like a GI virus or something, and that's why they were nauseous and vomiting. But in a child with a VP shunt, everything is, more concerning, because there's a risk that they might have a VP shunt issue. Okay, so those were kind of the early signs. These would be late signs of increased ICP, and when you really, need to intervene very quickly. So if they have a lowered level of consciousness, decreased motor response to command, decreased response to painful stimuli, flexion, extension, posturing, Cheney-Stokes respirations, that would be very bad, and then papilledema. So it's good to know what are early signs versus late signs, and then just know that these are very bad things, and if your patient exhibits these symptoms, then you need to call the doctor as soon as possible. Okay, so the treatment or nursing care for increased ICP. So you want to maintain neutral head position so that you can encourage CSF flow back to the body. You want to minimize noxious stimuli, give them a quiet, peaceful place to rest. Minimize suctioning. You can hyperventilate them on 100% FiO2. Raise their head a bed up, and then carefully assess their fluid balance so that they're not fluid overloaded. And then try to minimize how much they Valsalva, because that just increases ICP as well. Okay, head injuries. This is the leading health risk for children and the leading cause of death in children greater than 1 year of age. So we talked about all sorts of accidents and safety teaching, and head injuries is one of the worst accidents that can happen. It happens with falls, so a fall from high chair, bed, crib, window, or a motor vehicle injury. So especially if they're unrestrained in the vehicle, and then bike accidents. So children not wearing a helmet is really susceptible to a head injury. Okay, so the patho, trauma. If they have a traumatic brain injury, the severity is directly related to the force and impact. So infants are actually lucky in this case because they have elastic, pliable skulls, so they can recover very well from head injuries. Children are more likely to have the acceleration, deceleration injuries. Sometimes we talk about the coup, contra coup. And then, so the primary brain injuries that they can have from the actual trauma itself is a skull fracture, contusions, and an intracranial hematoma. Secondary to those injuries, they can have hypoxic brain damage, increased ICP, and infection or cerebral edema. Okay, so this shows coup, contra coup. So, they have the site of impact. which is the coup, and then the contra coup down at the bottom shows it's the area that the brain then moves within the cranial vault and collides with the skull on the opposite side, and so you have two areas of brain damage. Okay, so along with another type of head injury is a concussion. So a concussion is a transient reversible neuronal dysfunction with awareness and responsiveness for a short time. So it's a shorter, limited head injury. A contusion or laceration is a bruising or tearing of the cerebral tissue. It commonly happens with a skull fracture, and the symptoms are like transient weakness to paralysis. So if someone has a head injury, there's lots of complications that can happen afterwards, including they can have a hemorrhage afterwards that would cause a stroke, right? An infection or edema. And that peaks at 24 to 72 hours. So these patients, they're often on like diuretics and steroids, and they might have a drain to kind of drain off some of the pressure, because basically you're trying to just get them through that peak of edema without their brain becoming so swollen that it herniates and they die. So you just are trying to minimize the swelling. Okay. So a lot of times people say, do I need to bring them in? So these are the times when they should seek medical attention. So if a parent asks you or whatever, these are good times to go and get checked. So if there's a high speed injury, high fall, or great force, just makes it more likely that they're going to have some severe injury. If the child is greater than 6 months, less than 6 months old, if they are unconscious, if they have speech, vision, or gait changes, a headache that is severe or worsening or interferes with sleep, if they vomited more than 3 times, if they are having increasing swelling, if they're confused, lethargic, difficult to arouse, or pupillary changes. These are all bad signs and times when you would want to get a patient assessed if they have a head injury. Okay, so use your head, protect your brain, and help your patients do likewise. And this is the end of your neurology lecture, and email me if you think of any questions or aren't sure about something in the lecture. So happy 4th of July. Bye guys.